Yeah, good afternoon, everyone. I would like to welcome you to the today's Young Physicians Forum and the college lecture for the month of July 2023. So we'll start the first with the Young Physicians Forum. We have two presenters today, and the Young Physician Forum is kindly supported by CIPLA as usual. And so to start today's proceedings, I would like to invite Dr. P.P.B. Herath, Senior Registrar in Internal Medicine, Teaching Hospital, Anuradhapura, to talk on Propanil Induced Methemoglobinemia, the blue not to be missed. Over to you, Dr. Herath.
Good afternoon, everyone. Thank you very much, sir, for your kind introduction. And thank you, CCP, for giving me this opportunity. Today, I'm going to discuss this topic, propanil-induced methemoglobinemia, the blue not to miss. So, first of all, before starting, what is propanil? Propanil, or 3,4-dichloropropanolide, is a selective acelanilide herbicide using paddy cultivation in many parts of Asia and in Americas. Commercial products contain 36 to 48% of propanil, and it is co-formulated with surfactants and contains some impurities which may contribute to the toxicity. There's limited information about the clinical toxicology of propanil. Methemoglobinemia appears to be the most important manifestation with acute propanil poisoning, but still we see significant number of cases with propanil poisoning in our hospital setup. First of all, I thought of starting with this clinical scenario. This is an actual clinical scenario encountered by us, Teaching Hospital Anuradhapura. A 45 years old farmer from Rajangani was found to be unconscious at home. He had a history of recent alcohol intake and found with an empty agrochemical bottle by side. On admission, he was drowsy. GCS was 11 out of 15. He was silenced but hemodynamically stable. His respiratory rate was 22 breaths per minute and pulse oximetry value was 82% with clear lung fields. Activated charcoal is being given via an NG tube suspecting agrochemical self-poisoning. And he has been underwent an arterial blood gas analysis, and these were the results of ABG. pH was 7.466. Arterial CO2 partial pressure was 18.8 and oxygen partial pressure was 119.8. Bicarb level was 16.7 and saturation 99%. So today's my topic will be based on these subtopics. What is the pathophysiology of methemoglobinemia and propanil poisoning? What are the basic etiological factors, especially in acquired methemoglobinemia, and current status in Sri Lanka regarding this propanil poisoning, clinical presentation of acute propanil poisoning, diagnosis of propanil-induced methemoglobinemia, and management of propanil-induced methemoglobinemia, and finally, what's new and how can we improve outcome? Okay, what is methemoglobinemia? In normal hemoglobin, iron is in the ferrous state, which allows binding of oxygen in the lungs and it releases to the tissues. Methemoglobinemia is an altered state of hemoglobin in which the heme ion is oxidized to ferric state. The ferric methemoglobin do not bind oxygen. The ferric heme in the hemoglobin tetramer causes the remaining normal ferrous heme to have increased oxygen affinity as well. This produces a left shift of the hemoglobin oxygen dissociation curve, and this will turn further reduce oxygen delivery to tissues. This is a good old hemoglobin dissociation curve we learned in our physiology. So methemoglobin will increase oxygen affinity and reduce oxygen delivery to tissues, finally causing this hemoglobin dissociation curve to left side. Then, regarding the pathophysiology of propanil-induced methemoglobinemia, propanil is readily absorbed following oral, dermal, or inhalational exposures. And it is hydrolyzed by hepatic acclimidase in vivo to 3,4-dichloroaniline or DCA, which is in turn oxidized to 3,4-dichloropenyl hydroxyalamine, which is a potent inducer of methemoglobin. These reactions are similar to those of dapsone, which is the common encounter in clinical practice complicated with methemoglobinemia, and it is the same reaction happens with the propanil as well. These are some facts about this propanil. The elimination half-life of propanil in humans is around 3.2 hours. However, the concentration of its major metabolites, DCA, is generally high and more persistent and more variable than propanil. This is due to DCA having long half-life and being slightly less lipophilic than propanil and therefore likely to have a smaller volume of distribution. But considering propylene per se, it has a high volume of distribution because it is more lipophilic compared with this active metabolite. Then, what are the common causes of methemoglobinemia? My focus is on acquired causes of methemoglobinemia, but there are hereditary causes as well. There are three genetic causes of hereditary methemoglobinemia. First one is deficiency of enzyme cytochrome B5 reductase due to pathogenic variants in its CYB5R3 gene. That's an autosomal recessive condition. And second one is hemoglobin M disease due to pathogenic variant affecting one of the three globulin genes. That's an autosomal dominant condition. Then finally, deficiency of cytochrome B5, which is quite a rare condition. Then the commonest encountering causes of methemoglobinemia, the acquired causes, due to various exogenous substances and commonly dapsone and local anesthetic agents in day-to-day clinical practice. But these may include medication overdose as well as even the therapeutic doses as well, and some cases of poisoning such as in propanil toxicity. These are the medications which are commonly complicated with methemoglobinemia. So I'm not going to list out each and every cause, but commonly the dapsone and quinines like chloroquine, primaquine, and local anesthetic agents, including benzocaine, lidocaine, and prilocaine, can cause methemoglobinemia. Little bit of word about dapsone-induced methemoglobinemia. It's good to miss in this scenario because the propanil reaction is similar to dapsone reaction. Dapsone used in treatment of leprosy and acne vulgaris owing to its immunosuppressive effects. Long-term administration of dapsone at standard doses, even, that's 100 mg per day, results in methemoglobinemia in around 15% of patients. And topical dapsone as well for acne, Sweet syndrome results in methemoglobinemia levels even high as 20%. Then there are certain food and beverages can also complicate with methemoglobinemia. Those include frozen and dried foods that use in nitrites and sodium nitrate as preservatives, certain mushrooms, certain root vegetables which can concentrate nitrates, and well water which contains nitrates. Then the chemical and environmental substances. Several industrial chemicals like acetaldehyde used in varnishes, rubbers and dye, and even antifreeze, and finally the propanil. So what about the propanil poisoning in Sri Lanka? What is the current status? Propanil is widely used herbicide in paddy farming, both worldwide and in Sri Lanka, as I previously described as well. Most of the reported cases of poisonings are due to deliberate self-injection as an attempt to suicide. And most reported cases are in agricultural communities who has access to propanil. And propanil poisoning is the third most lethal herbicide poisoning in Sri Lanka. This is an interesting article published in Lancet 2021, the case fatality of agricultural pesticide self-poisoning in Sri Lanka, which is a prospective cohort study, according to which propanil just spots below paraquat and quincolac with the case lethality with 8.2%. But what happened in Sri Lanka? In 2014 December, our government has issued this extraordinary gazette banning propanil together with certain other agrochemicals in selected areas of our country, including districts of Anuradhapura, Polonnaruwa, Kurunegala, Monaragala, and certain divisional areas in Badula district as well, including Ridhimaliyadda, Mayangane, and Kandakati. Still, we see number of propanil poisoning cases even following the ban as well. So these are the evidence that even following the ban, we have had several cases of propanil poisoning. All the two cases I have gathered after 2014 published in Sri Lanka. One is propanil induced hemolytic anemia from my unit, Teaching Hospital Anuradhapura, and another from Teaching Hospital Basic Law, a new treatment approach for acute propanil poisoning, a case report. Then, back to the clinical scenario. I'm not going to read the clinical scenario again. I have highlighted certain things here. Patient found to be cyanosed and pulse oximetry was 82%. And his arterial oxygen partial pressure was 119.8 with arterial oxygen saturation showing 99%. So what was wrong with our patient? He found to be confused on admission and cyanosed as well. And peripheral pulse oximetry value was not improved with supplemental oxygen. And interestingly, he had this high saturation gap. What is saturation gap? Saturation gap is the gap between the arterial oxygen partial or arterial oxygen saturation together with the peripheral oxygen saturation. Our patient's arterial oxygen saturation value was 99%. But peripheral pulse oximetry, the finger pulse oximetry value was 82%. They are showing a gap of 70. And another important thing is, which I'm going to discuss later, this bedside color chart, which we can use to detect the severity of methemoglobinemia. We have used that, and the methemoglobin value was 70%. With the given history, with the given background from the this agricultural area, we diagnose him to have methemoglobinemia, possibly following propanil poisoning. So what are the usual clinical presentation or common clinical presentation following propanil toxicity? Most of the time, symptoms are non-specific, but only some may come with or label or the poison bottle. So mostly the gastrointestinal upset can occur, vomiting, nausea, even the GORD symptoms also they can have. They can have water level of consciousness in mostly moderate to severe propanil toxicity. They may be tachypneic on admission, but cyanosis is rare. Only 15% of patients coming with propanil toxicity will show cyanosis. But we should always suspect methemoglobinemia in an adult with unexplained cyanosis or hypoxia that does not resolve with supplemental oxygen. So how can we diagnose propanil induced methemoglobinemia? As a resource poor country, we don't have much the hi-fi laboratory tests for the diagnosis. These are the list out of things which we can use to diagnose methemoglobinemia in our context, but only the blue arrowed ones are the ones which are available in our hospital setups. There are these hi-fi blood gas machines available in other countries which will give the methemoglobin value in this interpretation sheet, which is not available in most of the blood gas machines in our country. Other thing is we can do co-oximetry, which is a specialized pulse oximeter that uses multiple wavelengths of light can be detect absorption of methemoglobin at certain wavelength. And this Eoling-Malloy assay, this is a chemical assay. It is hardly being practiced in hi-fi centers too. Then what we have is routine pulse oximetry and this arterial blood gas machine showing the arterial blood gas partial pressure and saturation of the arterial blood. Because these may be normal or falsely elevated despite severe methemoglobinemia. So the saturation gap plays a major role in detecting methemoglobin levels. Other thing is, this is also interestingly improved in our country. This simple bedside test to detect severity of methemoglobinemia. This is done and validated by a set of Sri Lankans in 2012. A bedside test for methemoglobinemia improved antidote use in propanil poisoning. So most of our emergency treatment units and wards occupied with this bedside color chart. Then how can we categorize severity of propanil poisoning? There are two schools of thinking. This one I have grabbed from this article, Clinical Outcomes and Kinetics of Propanil Following Acute Self-Poisoning, a prospective case series, came in year 2008-2009. So they have categorized the propanil poisoning into three groups: minor, moderate to severe, and the death. The minor asymptomatic or mild symptoms, moderate, whatever the intervention if the patient needed, required, that we can be categorized as moderate. The lethal dose in a man probably as little as 10 milliliters in undiluted compound, and ingestion of more than 200 milliliters in diluted propanil is usually considered as severe propanil poison. This is TAPNA, or Toxicology and Poisons Network Australia. They have categorized the acute propanil poisoning into four severity categories. First one is asymptomatic and mild, moderate, severe. Mild is mild GI symptoms with stable vital signs and no other organ involvement. Normal lactate and normal arterial blood gas values. Moderate is when the methemoglobin is less than 20% and or patient may be having mild acidosis, but pH should be more than 7.2. Hypertension, it usually should respond to initial fluid resuscitation. Then what is severe methemoglobinemia? If the methemoglobin value more than 20% is considered severe methemoglobinemia together with severe metabolic acidosis if the pH is less than 7.2. If the patient is hyperventilating, if the patient requiring intubation, if the patient is having oliguria with renal involvement, and also hypertension, which is not responding to initial fluid therapy. And if the patient going into cardiac arrest, coma, seizures, or death can be considered as severe methemoglobinemia. Management of propanil poisoning. This is the good old guidelines we have, good old the poisoning book we have. This is the management that is recommended in the current literature. For oral exposure, induced vomiting is not recommended. An activated charcoal can be administered or gastric lavage, if the patient presents within 1 to 2 hours of exposure, can be performed. If symptoms of methemoglobinemia are present, those including tachycardia, tachypnea, or confusion, or if the levels of methemoglobin more than 30%, we can give 1% methylene blue, 0.1 milliliter per kilogram intravenously, or 1 to 2 milligram per kilogram intravenously over 5 minutes as the initial therapy. But this dose may be repeated within 1 hour if there is no improvement. So in 1 hour time, we need to recheck the patient's clinical assessment as well as methemoglobin levels to consider whether he needs a repeat bolus. In large injections, relapsing methemoglobinemia can occur, requiring additional boluses of methylene blue as well. N-acetylcysteine and IV vitamin C, those are potent antioxidants, are also alternatives but not commonly used in our practice. The US FDA warns against using methylene blue concurrently with serotogenic psychiatric drug that we need to keep in our mind. And finally, the exchange transfusion can be life-saving in severe poisoning not responding to above drugs. An exchange transfusion can improve oxygen delivery by donation of erythrocytes. So that is the basic mechanism of action in exchange transfusion. Finally, what had happened to our patient? Patient was initially given multiple dose of methylene blue, and patient had to undergo elective intubation because of persisting low peripheral saturation and persisting low level of consciousness. And later he was sent to this ICU, and he has underwent exchange transfusion as well. And he made full recovery in few days' time. So the final and the most important part of my discussion. So what is new in propanil poisoning and how can we improve outcome? The current management of propanil poisoning is being practiced for decades. There are several new methods have been tried in treatment of propanil poisoning. So I am going to discuss a couple of things which are coming new in management of this propanil toxicity. So first one is, what about single dose activated charcoal compared to multiple dose activated charcoal? This 7-year retrospective cohort study, which came from Thailand, discussing the clinical characteristics, treatment, and outcomes of acute propanil poisoning. According to it, majority of patients were treated their centers with multiple dose activated charcoal, but none of them had developed any complications due to multiple dose activated charcoal as well. And multiple dose activated charcoal has shown improved clinical outcomes who have been initially treated with multiple dose activated charcoal according to their study. But there is this controversial study, again come from Sri Lanka. This was published in Lancet 2008. Multiple dose activated charcoal in acute self-poisoning, a randomized control trial. According to that, this is the forest plot. So there it is showing there is no significant benefit giving multiple dose activated charcoal to certain poisonings. That includes organophosphate, oleander, certain medications, and certain other non-categorized poisons. But interestingly, they have not specifically checked for propanil. So still we don't know what is the action of multiple dose activated charcoal in propanil. There are no randomized control trials available. Then the second important thing. So the thing we are practicing is frequent boluses of methylene blue. Why can't we consider continuous infusion? Still, that is there in the recommendation in the TAPNA. So in the TAPNA is the Toxicology and Poisonous Network Australia. They recommend for severe propanil poisoning, we can give initial bolus 2 mg of methylene blue as bolus injection over 1 minute, followed by an infusion 10 mg per hour for 10 hours duration. The methemoglobin concentration should be reassessed within 1 hour of commencement of the infusion. If methemoglobin more than 20%, a further bolus injection of 2 mg per kilogram should be given, and the infusion rate can be increased by 50%. If the methemoglobin falls below 20%, then the infusion is maintained at the current rate. But methylene blue itself is toxic. The maximum recommended daily dose of methylene blue is 7 mg per kilogram. But toxicity has also been reported following dose of low as 4 mg per kilogram. Adverse effects of methylene blue, including the general things like nausea, vomiting, diaphoresis, burning sensation of mouth and fingers, and even abdominal pain. But severe toxicity of methylene blue causes hypotension, exacerbation of methemoglobinemia, and finally hemolysis. Still, our poisoning book and our guidelines and the guidelines available not recommending methylene blue as a continuous infusion in severe methemoglobinemia. There are no randomized control trials available and no guideline recommendation currently. What about exchange transfusion? Is the exchange transfusion a lifesaver compared with methylene blue? There are several case reports has shown early initiation of exchange transfusion has good outcome in moderate to severe propanil poisoning. Repeated administration of methylene blue may delay the exchange transfusion and increase the risk of end organ damage. So the early initiation in this exchange transfusion will prevent this establishment of end organ damage in severe propanil poisoning. This is also a case. The exchange transfusion can be life-saving in severe propanil poisoning. Case report coming from National Hospital Sri Lanka. So, what are the other potential alternatives? Exchange transfusion. Do we need to always the transfusion physician to manage? Of course, no. There are certain new treatment approach for acute propanil poisoning. This is also a case report. This is also being practiced once in, as I encountered in Batic flow. They have done venesection as a measure to remove the methemoglobinemia red cells, followed by donor blood transfusion. That's the same thing happening with the as the exchange transfusion. Finally, when to discharge. There are no clear-cut guidelines when to discharge a patient with acute propanil poisoning. Most of the time, methemoglobin appears within first 24 hours following acute poisoning. But in some, this may delay beyond 48 hours as well. But hemolysis can be a delayed manifestation. It can go even beyond 10 days. And usual median hospital is 3 days following acute propanil poisoning. That is according to this retrospective cohort study done by this Thailand group. Okay. So in past few years, there were multiple admissions of propanil poisoning to teaching hospital Anuradhapura. That's why I selected this topic. And currently, we are analyzing 56 propanil poisoning cases admitted within last 3 years. So that is not a rare thing to present to a center which is within the agricultural community. There are around 2 cases per month line. Furthermore, still there are limited literature available regarding management of propanil poisoning, and there are a lot of knowledge gaps as I have discussed previously. There are still no randomized control trials and systematic reviews available regarding current treatment modalities and even some outcomes as well. Okay, the final part of my presentation. What are the take-home messages? These are my take-home messages. Cyanosis is not always present in propanil poisoning. And we should suspect methemoglobinemia in a cyanose patient who is not improving with oxygen. And saturation gap. It's an important indicator of methemoglobinemia. In absence of other causative agent, consider possibility of propanil poisoning. Bedside validated color chart is an important tool in determining severity of methemoglobinemia in Sri Lanka, though it is highly operator dependent. And the multiple dose activated charcoal can be considered instead of single bolus. An early initiation of therapy with exchange transfusion may be life-saving in severe propanil toxicity. Thank you.
It's open for questions.
Thank you, Dr. Hiran, for that detailed presentation. I think you said that exchange transfusion, what is the exact timing of that? Is there any evidence to say that from your center or from other centers?
Yes, early initiation of exchange transfusion in severe propanil toxicity, sir. But because severe propanil toxicity, initial we practice is giving hourly methylene blue boluses. But we don't know when to resolve this methemoglobin in those patients. So it can go even hours and hours. So the studies that I have gone through the previous case reports in our center, according to them, they can go for hours and hours. So if it is going for hours and hours, that will result in more end organ damage and more poor outcome. So early initiation of exchange transfusion is a salvage therapy for the rather going for methylene blue. If we initiate early the exchange transfusion, it can prevent this end organ damage, which will be established with ongoing methemoglobin if you give boluses of methemoglobin.
So the center procedures do it early, you recommend
yes,
done very
early. Intrahepatic circulation, we still don't know. That may be the reason that they are recommending multiple dose activated charcoal, so that will prevent this intrahepatic circulation. But still, that's not been studied. So, but the metabolization happened to this active form, which is more nasty, that happens in liver. Yeah, so because there are no randomized control trials, but according to retrospective studies, not in our country, but in Thailand, they have done a good study, 7-year study. According to them, majority of the patients underwent multiple dose activated charcoal without any complication, and they had improved outcomes.
They are quantifying the methemoglobin.
if you have this hi-fi blood gas machine, so that will give a quantification. So, and other thing is this this chemical assay as well. So that is not in the very hi-fi centers available. Quantification can be done if we have this the appropriate blood gas machine.
Okay. In absence of any more questions, thank you very much, Dr. Herat, and please accept the token of appreciation, certificate of appreciation from the college.